Title: Managing Urinary Incontinence in Primary Care, Sharing Progress and Resources from AHRQ's EvidenceNOW initiative. Monday, November 6, 2023, 2 p.m. to 3:30 p.m. Eastern Time, 11 a.m. to 12:30 p.m. Pacific Time. Logos: AHRQ Department of Health and Human Services, Agency for Healthcare Research and Quality, and EvidenceNOW, Managing Urinary Incontinence, an AHRQ initiative. Elizabeth Cope.
All right, welcome everyone. Welcome everybody to today's webinar. I'm happy to have everyone join us. This is our second annual public webinar for the Managing Urinary Incontinence initiative. This initiative is part of the Agency for Healthcare Research and Quality's EvidenceNOW portfolio, which you're going to hear more about in just a moment. Today, we're excited to be providing an update on progress and sharing out some key resources for all of you. Hosting you today is the Initiative Support and Evaluation Center, and that is a partnership between RAND and Academy Health. And the Support and Evaluation Center Project Director, Peter Mendel, is joining us today on the Zoom. My name is Elizabeth Cope, and I'm a Vice President at Academy Health and Project Lead for the Academy Health team in partnership with RAND. And I'll be serving as your MC today, and I'll be joined by my colleague Sarah Hoyt during the Q&A to help with facilitation. Before we dive in, I have just a few housekeeping comments. So you'll note that there are separate chat and QA features in the Zoom today. The chat allows you to engage with other participants and the speakers, and the Q&A is where we would like you to put your questions to the speakers. And we'll have a team monitoring both windows throughout, but we'd love it if you could be posting your questions to the speakers throughout and doing that in the Q&A chat window. Additionally, any materials related to this webinar will be posted on the AHRQ website, and the link for that site will be posted later in the webinar. And of course, you can always reach out to us via email as well. All of these links, as I mentioned, will be shared later in the webinar. So next slide.
Webinar agenda. 1. Welcome. MUI. Why, how, and so far. 2. Practice change resources for improving UI care. 3. Moderated Q&A. 4. Closing.
All right. So I'd like to give a quick preview of the session, and then we can jump on in. So first, we're going to hear from Tess Miller, who will place the initiative in context within AHRQ's broader portfolio. She'll be followed by Jill Huppert, who will share major updates from the most recent year of the MUI project. And then we're going to hear from each of the participating grantee teams, and they're going to focus on some key resources that they've developed over the last year or so, and how those could be adapted to other primary care practices. And we'll be focusing on items that we will be able to share later through the AHRQ website. Following their presentations, there's going to be an opportunity to hear from all of you and allow some direct engagement with the speakers through Q&A. So as I mentioned before, please be dropping your questions into the Q&A window throughout, and Sarah and I will be ready to elevate those questions to the speakers. So thank you all for coming. Thank you so much for your attendance and your attention, and thank you to AHRQ for this initiative and for making today possible for all of us. Without further ado, I'm going to turn things over to Tess Miller. Thank you.
Welcome and introduction to AHRQ. Therese Miller, Doctor of Public Health, Director, Center for Evidence and Practice Improvement, AHRQ.
Thank you. I'm really excited to be here and welcome everyone. Thank you so much for joining us today to learn more about this project that we've been working on a couple years now. I also want to start by thanking AHRQ staff, our principal investigators and their teams, and our contractor and its team for all the hard work to get us to this point so far. Next slide, please.
AHRQ's mission statement. www.ahrq.gov.
Hopefully everyone on the webinar today is very well acquainted with AHRQ, but just in case you're not, I thought it would be important just to share a little bit about our mission statement, for example. So we work to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable. And one way we do that is really working with HHS and other partners to make sure that the evidence is used and understood. So we're not really looking to create research that just sits on a shelf. We want to make sure that it gets into practice. Next slide, please.
AHRQ's role. Graphic. 4 squares illustrating the roles of different agencies. AHRQ research for healthcare. NIH research for cures. FDA research for drug safety. CDC research for public health.
And they're just really putting us in the context of our sister agencies within the Department of Health and Human Services. What we're trying to show here is that AHRQ is focused on doing research about the delivery of care. So for example, how do the cures and the new technologies and other research done by our sister agencies really get into clinical care? Next slide, please.
AHRQ's role in health system transformation. Infographic. 3 columns illustrating the elements of AHRQ's role. 1. Our goal, why? Improve the lives of patients. 2. Our aim, what? To help healthcare systems and professionals deliver care that is high quality, safe, equitable, high value. 3. Our competencies, how? Health systems research, practice improvement, data and analytics.
And the way that we do that is through 7 what we call our competencies, which is health systems research, practice improvement, and data analytics. And I think this is this project is a great example of some of the work we've done in practice improvement. Next slide, please.
AHRQ's EvidenceNOW initiative.
So back in, AHRQ has had a long history in really thinking about how to transform the delivery of care to make it higher quality. And back in 2011, we got a new mandate under the Affordable Care Act to really help implement new patient-centered outcomes research findings into clinical practice. And since 2015, we've been focusing on a model that's really centered in primary care, and really to better understand how you can provide external support to primary care practices, both independent, but also more and more within health systems to improve the care delivery. And we started in 2015 with a project focused on advancing heart health. And that project, I will say, was one of our biggest ones. And we really wanted to better understand how can you set up a system to provide external support to primary care practices. Will primary care practices want to use these services, and does it have any impact on heart health? We really used a mix of implementation science as well as quality improvement services and strategies to try to do that. We learned a lot through that project, and we had the opportunity to move on to use the same model, but to better understand different aspects of primary care and building this capacity within primary care. So we have gone on to fund a project about building state capacity to advance equity in heart health. So there we're trying to better understand what it takes to set up what we call cooperatives, but entities that support primary care practices within a state and have them focus on 2 aspects of heart health, which are blood pressure control and smoking cessation. And in that project, we are working in states that have a high rate of preventable CVD events. Clearly, we also wanted to better understand how you can do this in behavioral health. And so we had a project, there was new evidence around managing unhealthy alcohol use in primary care. And so there we're trying to really better understand how do you integrate behavioral health and what does it take to implement a behavioral health topic in primary care. And then lastly, we were very fortunate to partner with PCORI. There was new evidence on managing urinary incontinence, non-surgical treatments for managing urinary incontinence in primary care practice. And we really wanted to understand there how to better connect primary care with specialty care and also with community-based organizations to ensure the highest quality of urinary incontinence care. Next slide, please.
EvidenceNOW, key driver diagram and tools for change. Flow diagram illustrating the key drivers to achieve AHRQ's aim. Each key driver is implemented using change strategies, and each change strategy has specific tools and resources related to that key driver. https://www.ahrq.gov/evidence-now/tools/index.html.
Fundamental to all that work is we want to share what we're learning with a larger community so that if you're not involved in one of the actual sites or grants, that you have access to the resources and knowledge that all of our PIs and sites are creating. So we do have a collection of tools available on our website, which you're seeing here. We continue to add to this, and these are tools that have been developed and one of the EvidenceNOW projects, but also tested within the project. So I invite you to go there. And I think one of the real reasons and why this webinar is so important to us today is that we're going to tell you about a lot of new resources focused on managing UI in clinical practice. With that, I'm delighted to turn it over to Jill Hubbard, and she's going to give you an update on where we are.
MUI, why, how, and so far. Jill Hubbard, MD, MPH AHRQ. https://www.ahrq.gov/evidence-now/project/urinary/index.html.
Thanks very much, Tess. As she said, I've been involved with the Managing Urinary Incontinence initiative since the early days, and I'm going to tell you why we did it, how we're doing it, and where we are so far. Can I have the next slide, please?
Assessment. Why urinary incontinence? Public health burden. 40% women report any UI, approximately 30% older women report moderate severe UI. Effective non-surgical interventions, behavioral, medications, neuromodulation, combinations, patient-centered outcomes, symptoms, quality of life, high social impact, cure, evidence practice gap, less than 40% screened in primary care, less than 50% with symptoms seek care, 30 to 50% treated, role of primary care, early identification and treatment, efficient use of specialty and community resources.
So why urinary incontinence? Well, first off, when we started this, we weren't in a pandemic. And we knew that we had about 25 million women in the United States who were affected with urinary incontinence, with a large public health burden. As Tess mentioned, PCORI had sponsored a systematic review that we did here at AHRQ that showed that there were effective non-surgical interventions, behavioral medications, or combinations of those that would improve symptoms that are important to patients, symptoms, quality of life, and even cure surgery. So criteria to this topic is really ready to be disseminated and implemented in a broader setting. And we found that there was an evidence to practice cap with women getting screened, women getting the care they need, and it's applicable for primary care.
I am going to jump in real quickly here because it looks like we are losing Jill. So we may need to come back to Jill for the rest of her presentation. Let's see.
And here I am.
You okay?
I'm back. Okay, well, take the next slide. So we knew that primary care was juggling a lot of things, and then we threw COVID on top. Next slide, please.
The EvidenceNOW model for the MUI initiative. Illustration of a funnel containing evaluation, grants, and resource center, leading to the goal of improving non-surgical treatment of UI for women in primary care.
And we went with this EvidenceNOW model that Tess has described, with a suite of grants and an evaluation and resource center that's managed by our RAND and Academy Health colleagues. Next slide.
Map of the United States. Grantee states are highlighted in yellow. Grantee states include California, Wisconsin, Illinois, Ohio, and Alabama, Georgia, and South Carolina circled as a group. Blue stars indicate contract states. States with blue stars include California and Washington, D.C.
This is the geographic reach of our grantees pretty much across the country. Next slide.
Grantees have unique features. Table indicating MUI grantee projects and what sets them apart. WI Intuit, UW Madison. Streamlined practice facilitation. Menu-based intervention. 5As. Community partnership building. Pursuit UAB VAM Health Toolkit, My Healthy Bladder, Data Dashboard, Consultative Services. IT2 Northwestern. Automated UI screening and computerized education, Wiser Care. Empower Cleveland. Nurse Navigation Care Pathway, AI Conversation Platform, CEAS, ECHO. UC San Diego UCSD Practice Facilitation Diodes. Four-pronged approach, academic detailing, clinical decision support, electronic referral, app co-management.
And each of the grantees have unique features, and you'll be hearing from them about what they're doing differently to try to get urinary incontinence care into practice, such as streamlining practice facilitation using mobile health or automated screening, nurse navigation. Those are some of the things that you'll be hearing from the participants when they do their presentations. Next slide.
Progress at the halfway mark.
One thing I wanted to share with you, if my internet doesn't die again, is how the whole initiative has made progress so far. We are 18 months into these 3-year grants. And the next slide, please.
Practices reached across the initiative. 98% of initiative goal met equal success.
So our goal was that the grantees together would reach 250 practices. The grantees set themselves a better goal, which is 290 practices, and so far they've recruited 246 primary care practices, which is amazing success. Next slide.
Total women screened for urinary incontinence. 48% of initiative goal met equals excellent progress.
And we also set a goal of reaching 35,000 women. And at the halfway point, so far, we've screened nearly 17,000 women, which again, at the halfway part is really great progress for the initiative. Next slide, please.
Women identified with UI.
And we have some grantees reporting of the women screened.
Over 9,000 women.
At least 49% are reporting at least one urinary incontinence symptom, which is showing us that we really are just at the tip of the iceberg. Next slide, please. And of the one grantee who's giving us this data so far, in a small group of
428
women who reported that they had bothersome urinary incontinence symptoms, an astounding 58% still want treatment, have not been, are wanting treatment. Only 10% have already been treated, and about a third,
32%,
are kind of content with their symptoms the way they are and are not asking for treatment. Next slide. So we're making progress towards helping that juggling primary care practice get to better care for women. And the resources, the way we're doing this is what we really want to share today, to have the grantees tell you how they're doing and provide you some of those resources so that you could take them home and apply them in your own practices. And again, sorry for my internet today. Take it away.
Thank you so much, Jill. All right.
Practice change resources for improving UI care. WI Intuit, Pursuit, IT2, UCSD, Empower.
We are going to be moving into our presentations from the grantee teams, and we will be starting with the Empower team, and we have Adonis Hijaz here to give that presentation, so thank you.
UI Web-Based Care Pathway, Empower team. Adonis Hijaz, MD, Lester Persky Professor of Urology, Case Western Reserve University Vice Chair of Academics and Research for the Urology Institute, Senior Attending Surgeon, Urology Institute, University Hospitals Cleveland Medical Center.
Thank you very much for allowing me to present today on behalf of the entire Empower team. I'm Adonis Hijaz. I'm the co-PI with Gautam Rao, who's the Chair of Family Medicine, being on the call today with me. Next slide. Today, what we were going to be talking is about one of the tools that we have been utilizing internally within the within the Empower study, and we have developed it for the purpose of the Empower study. So just a quick overview. The goal of the Empower study is to implement the Empower program across the large network of primary care practices to improve the diagnosis of incontinence and promote non-operative management. This is done by both empowering patients as well as physicians, identifying the barriers, and we're trying to achieve removing these barriers. So the team is involved with Primary Care Institute, Urology Institute, Case Western, Population and Quantitative Health Sciences, and the population of focus is women in Northeast Ohio. And intervention is multifaceted. It includes education, one-on-one nurse navigation, and interactive AI chatbot via a smartphone or a tablet. Next. So what are the needs that we identified? We think that primary care providers need an easy-to-access tool to guide their care of urinary incontinence. Obviously, as you well know, providers are not addressing incontinence on a daily basis. There is no quick, easy, and effective tool that exists to identify the levels or the lines of therapy for urinary incontinence. And it's also, there is no tool that the rest of the care team, not only the provider, that they can familiarize themselves with the algorithms or the flow or the care pathways in the treatment of incontinence. So that's what we identified as a need. The challenge is to create such a tool that can be utilized by everyone. Initially, we wanted to create it for our nurse navigators to take the algorithms that exist in the literature into a workable flow sheet. And then once we establish that, the other challenges for providers to accept the utility or utilization of this tool in their workflow. Next slide.
Care pathway features. Use of the UI web-based care pathway begins by assessing if the patient needs treatment for stress urinary incontinence, SUI, urge urinary incontinence, UUI, or both, MUI. Therapy options start as behavioral modifications and progress to medication management, device management, and eventually specialist referral surgical management.
So essentially, the care pathway feature starts by identifying what type of incontinence the patient has, and the therapy options will follow once you place the patient in one of these categories. Next slide.
Flowchart, visual representation of the care pathway based on the published algorithm and methodology on incontinence management.
So this is a busy slide, but the purpose of this slide is to show you the sample of what we have created. So we took the published algorithm from the Society of Urodynamic Female Urology and other societies in the management of incontinence, and we created this web-based flow sheet. So this tool is easy to guide providers through the treatment of urinary incontinence. It's accessible online. There could be a short cut on the smartphone. It has a flow sheet design, easy to follow. So if your patient has urinary incontinence with overactive bladder, like here, you follow this algorithm, and this if you have stress incontinence. And the most important feature that I think our team has worked into is creating clickable resources linked to each of these bubbles. So as my team is working, you can click on one of these categories and would pull resources that are available for the navigator that they can share with their patients. So I think this care pathway feature allows our individual nurse navigators, our team, to take the patient through the incontinence journey. Next slide. So this web-based care pathway development was developed by our team. As I said, Elisar Kawam, who's the project manager, took the lead on creating this. It's developed using a Google tool that's free, accessible, and available to everyone. This is draw.io. An Empower project manager collaborated with the Urology Institute stakeholders for expert advice on specifics of the care plan and subsequent finalization of the pathway. It was researched and identified appropriate, trustworthy resources for integration within the pathway, especially in these bubbles that we were talking about. And next slide, please. The Success and challenges. This web-based care pathway has only been utilized so far by our study team. So our nurse navigators are using it when they plug the patient into the pathway to see at what level in the care pathway the patient is. They have used it and they found that it's full of resources, and resources were useful to them. The implementation phase of this tool is still in process. We will eventually receive feedback if practices and providers choose to use it in the sustainability menu. I know that this tool is available as we exit from each of these sites, available to give to the sites to see if they want to pick it up and use it in their sustainability menu. We strive to make a user improvement on this tool, more graphic aspects that be more visually appealing to the user, improved ease of use, and using keywords to cut down on the wordiness that you see on the tool itself. Next slide. So the uptake consideration, obviously we need something that's user-friendly interface, no need to be tech-savvy, can be utilized in a variety of ways, even outside the Urology Institute, to create a care pathway for many other conditions. Health systems can use this program to customize their care pathway to their own practices.
Contacts, resources, helpful links, referral lists, etc.
Obviously, they can take that skeleton that we've built and then they build on it depending upon their way of management. And the pathway could eventually be used as a presentation tool for patients as we talk to them about their position on or their journey on this pathway. So as I said, this is one of these tools that we have developed for the internal use of the team, but I think it will have significant utility as we move forward in sustainability phase of the study and make sure that we empower the offices and the management of incontinence. Next slide. Thank you. And that's the end of my presentation.
Thank you so much, Adonis. We appreciate that. And now we will be moving to the Wisconsin Intuit team, and representing the team will be Heidi Brown.
UI Launch Toolkit, WI Intuit Team. Heidi Brown, MD, MAS, University of Wisconsin-Madison, Kaiser Permanente, Southern California.
Hello, good morning or afternoon. I am presenting on behalf of the Wisconsin Intuit team, which includes my co-PIs at Medical College of Wisconsin, as well as Metastar. Next slide, please. So the goal of our project is to compare the impact of two different implementation strategy bundles on screening and treating urinary incontinence in diverse primary care practices across Wisconsin. And so the two different bundles, one incorporates partnership building and the other is streamlined practice facilitation without partnership building. And the tool that we're presenting today is one that's used for all groups, so everybody gets streamlined practice facilitation. What's unique about our project is that we're not working within a single health system. We're actually enrolling all sorts of different practices across the state of Wisconsin, including rural practices, independent practices, federally qualified health systems, tribal practices, facilities that have residency programs affiliated and facilities that don't. So a bunch of different settings. And our project team includes representation from internal medicine, urogynecology, patient-reported outcomes measurement, health systems engineering, and implementation science. Next slide, please. The need that we wanted to focus on for the tool we're sharing this morning or afternoon is the need for streamlining. So all of our participating practices have both common needs and unique needs. And so we wanted to be able to share things with folks, and we wanted the tools to be living documents that could be iteratively revised, because so often in medicine we use whatever we got and then it doesn't get updated easily. And disseminating information using email or multiple email attachments results in people being frustrated and not clicking on all the attachments, and nobody really has extra time to spare to figure out all the resources that we're trying to share with these busy practices in different settings. Next slide, please.
Screenshot table of contents for Intuit Urinary Incontinence launch materials. This document contains links to and descriptions of materials needed for your practice to launch urinary incontinence screening and treatment. Table with 2 columns, resource link and description. UI algorithm. The urinary incontinence treatment algorithm is for providers to refer to when encountering a positive screen for urinary incontinence and follow-up steps. UI Screeners English. This document contains options for screening for urinary incontinence in practice. UI Screeners Spanish. This document contains options for screening for urinary incontinence in practice for Spanish speakers. UI EHR Materials. This document contains options for note text and after visit summary language to be included in your EHR UI patient info. This document contains links to urinary incontinence handouts, education videos, and signing up for a Mind Over Matter, Healthy Bowels, Healthy Bladder class. UI 101. This 11-minute video will be shared at the beginning of the launch meeting and is available here for reference. Mind Over Matter Flyer. This is a flyer to hang in your clinic informing patients about Mind Over Matter, Healthy Bowel, Healthy Bladder classes.
And so we created this implementation toolkit that has standard resources that every participating practice can customize. And then we also give them some customized resources as well. But the table of contents that is the toolkit, the launch toolkit, has documents that can be revised by us without sending out new links because it's a Google document that has the links to other Google documents within it. A single link opens this manageable table of contents, and then people can click on the link to get to the tools that they need for their practice. We also realized that people didn't necessarily take the time to click through the link, so we created a little 2-minute video that explains the toolkit and how to use it. Next slide, please. To develop the toolkit, we had focused on this menu-based approach where we would give practices sort of the key components and let them pick and personalize. We have continued to do iterative revisions based on feedback from practices. We continue to learn that less is more and that folks really need things to be simple, echoing some of Adonis's findings, our goals of facilitating clearer, more streamlined, fewer words, all of that stuff resonates with our team and what our experience has been. Next slide, please. Our implementation toolkit has been widely used by our implementing practices, and we've had successful revisions of source documents within the toolkit link. So when we make an update, it still works and nobody's emailing us saying that that their links no longer work. Our practice change champions, the way we work with each individual practice is that they have a change team that disseminates to their practice how they're going to do the screening and treating urinary incontinence. And we found that the practice change champions might be enthusiastic, but weren't necessarily sharing the toolkit materials with the larger practice. So we modified and created this little worksheet to help the practice change champions identify which parts of the toolkit they were going to use in their practice to share with their other team members. Next slide, please. In terms of uptake, so this document that we're sharing with you, the toolkit link, the Google document toolkit link, is general but can be tailored and personalized by practices. So we do supplement this tool with a local list of resources for all practices, whether or not they're in the partnership building arm. We also developed a blueprint for other sites to be able to supplement within their local context, creating their list of local resources with a free national resource searching mechanism. So we use some publicly available national search tools to create the local resource list so that if you're in Nebraska and you wanted to do the same thing, you'd be able to do that. Next slide, please.
AUGS website, Patient Services tab, arrow pointing to the urinary incontinence screening menu option. Screenshot Voices for PFD website, arrow pointing to the Find a Provider in the top left corner of the page.
And then the toolkit is in itself a link to other resources. And we have a partnership with the American Urogynecologic Society, or AHRQ, where they will actually maintain this tool on their website. So one of the things we always worry about as researchers is when the grant runs out, who's going to continue to maintain the materials? When the study website is defunct, how is this going to go? And so we were intentionally partnering with the American Urogynecologic Society, which has a vested interest in treating women with urinary incontinence. That's sort of core to their mission. And so they are actually hosting these materials on their website. They even have urinary incontinence screening with a little link. And so they will, even after the grant is done, they'll continue to maintain those links and update them. So we're really excited about that. I believe this may be my last slide, but click next just in case. Okay, I was right. Thank you all very much. I welcome your questions.
Thank you so much, Heidi. We are moving now to the Pursuit team, which is going to be represented today by Camille Vaughn.
Patient Recruitment Flyer and Clinician Pocket Guide, Pursuit Team, Camille Vaughn, MD, MS Associate Professor, Emory University, Atlanta Site Director, Birmingham Atlanta Geriatric Research, Education and Clinical Center, Atlanta VAHCS Continence Clinic Director.
Hi, thanks so much. It's great to be here. So I will be telling you a little bit about a couple of resources that the Pursuit team has developed for both our patient partners as well as our clinician teams. And we can go on to the next slide.
Project, Team and Partners, MPI, UAB School of Medicine, Elaine Markland, Emory University School of Medicine, U.S. Department of Veterans Affairs, Co-Eyes Andrea Charrington, Lisa Zubkoff, T. Mark Beasley, Beverly Williams, Katharina Echt. Staff, Kayla Reinecke, Johanna Bors, Hannah Burns, Stephen Yu, Teresa Sargent. Partners, Ursula Kelly, Janice Phillips, Zach Birmingham, Angelica Caria. My Healthy Yvette, VA Women's Health Research Network.
Just to give you a reminder of the great group of folks that are working together as part of Pursuit. We are a collaborative project between the University of Alabama at Birmingham and Emory University, as well as our Geriatric Research Education and Clinical Center, or GREC, within the Birmingham and Atlanta VA healthcare systems. We have partners that are involved in implementation science, practice facilitation, primary care, implementation research, qualitative and program evaluation colleagues as well. We also have important partners through the Salt Lake City VA informatics team to really leverage the power of the VA's clinical data warehouse infrastructure, as well as part of the Pursuit program. And so just to give a shout out to all the great folks that have been working on the Pursuit program outreach. The next slide. So our overall goal is to, as all of the projects in this AHRQ program are, to improve access to non-surgical treatment of incontinence through primary care practice facilitation. And the Pursuit program, we are specifically focused on women veterans, and we are targeting practices in a region of the VA healthcare network called EvidenceNOW. That's a Veterans Integrated Service Network that encompasses practices from Alabama, Georgia, and South Carolina. Overall, we're aiming to improve incontinence symptoms for women veterans, and our practice facilitation includes increasing access through a mobile health application that women veterans can use in a self-directed treatment to access evidence-based non-surgical treatment. And then we also provide the opportunity for clinics to access a telehealth consultation option with a continence specialist. However, the sites are kind of randomized at the amount of highlighting that option versus trying to direct more users to the mobile health application, which is called My Healthy Bladder. All right, and we'll go on. So we, again, are targeting primary care clinics throughout the VA healthcare system across Alabama, Georgia, and South Carolina. That kind of shows you that Vision 7 on the map there. We enroll clinics that have at least 50 women veterans who are assigned to that particular clinic practice. And our goal is to provide treatment for at least 7,000 women veterans. We've actually already exceeded the target as far as screening women veterans at that 7,000 number, which is really exciting. So I think we will exceed that. On the next slide. So some of the things that we identified as potential barriers and needs to help make access to evidence-based treatment kind of easier within the workflows of primary care is to create as many opportunities and routes as possible for women veterans to access treatment. So while, of course, we expect that some women will mention these symptoms to their provider, or their provider will ask about them, we hope to increase that as well. We know that sometimes there's stigma attached to living with urinary incontinence, and some women may not feel comfortable discussing these symptoms with providers, even though they would like to seek treatment. So we've tried to develop tools that will allow women to self-refer, particularly because evidence-based treatments often begin with behavior and lifestyle-based options. So I'm going to show you one of our resources that we developed that actually, again, allows a woman veteran to self-refer both through a screening questionnaire that they can access, or to contact our team if they don't feel comfortable kind of talking about that with their clinical team. The other piece that we know, and it's been mentioned by others, is that primary care clinicians are really busy. They're managing multiple conditions for their patients, and sometimes kind of having that kind of what we call at the elbow support right there next to them when they need it, to give some quick guidance of common diagnosis codes of urinary symptoms that are the most frequently experienced by our patients, as well as in the VA system, being aware of some of the treatment options beyond behavioral and lifestyle-based treatments. If they're going to consider another type, maybe a drug-based treatment, what are some of the formulary considerations within the VA? Because we do have a pharmacy management service that's going to provide kind of recommendations about which types of pharmaceutical treatments they might consider first. So we wanted to provide some resources for clinicians to kind of make it easier to not only identify, diagnose common urinary symptoms, including incontinence, but also to be aware of some of the resources available for patients, both from drug treatments as well as some containment solution options that VA also provides. We are unique in that respect as well, that VA does provide some like absorbent products, including briefs, pads, things that would permit a veteran to not necessarily have to spend out-of-pocket money on some of those types of items. So I'll show you some resources that we developed as well for our VA clinicians.
Example of a patient recruitment flyer for practices recruiting patients for the Pursuit Managing Urinary Incontinence Project, U.S. Department of Veterans Affairs. Do you have bladder trouble? If so, you may qualify for a program for women veterans with difficulty controlling their bladder. You may be interested if you are experiencing accidental urine leakage or urgency, a woman veteran, 20 years old or above, and you are willing and able to answer questions about your medical history. Access the internet using your cell phone or computer. Individuals who are interested will be enrolled in an online education program called My Healthy Bladder for 12 weeks. Compensation is provided. All treatment is provided at no charge. There are no in-person visits. If you are interested in learning more about the program or determining if it is the right fit for you, please scan the QR code or email us at vhabirpursuitstudy@via.gov clinicaltrials.gov NCT number 05438849. Demo QR code.
So first here, this is a flyer that was developed for our clinics, and that we actually also directly send to women veterans that are enrolled in clinics that have received kind of the initial introductory kind of kickoff session for joining the Pursuit program. And you'll see here, again, this is a demo version, so don't scan the QR code with your phone or anything. But we basically provide patients direct access to that My Healthy Bladder kind of screening questionnaire and to potentially enroll in that treatment platform without needing a consult from their clinical team. So they can actually email, call our team, or if they scan that QR code, they're going to go to a Qualtrics survey that's behind the VA firewall that allows them to begin to engage with the Pursuit team to determine if they are a good candidate for the My Healthy Bladder mobile health application, which again is available to women veterans in our region. So this gives, again, some brief overview of the program and some information about how, again, they can directly access it. And we'll show you just a little bit of the information about how many women veterans have been pursuing this option that doesn't require a clinician consult.
Urinary incontinence, diagnosis, treatment, and products at the VA. Initiate lifestyle and behavioral strategies first. Refer veteran to the Pursuit team. VHABIR Pursuit study at va.gov. 2-column table of incontinence products and skincare by item and department. Liners, possible NF requests from pharmacy. Pads, assess need for extended coverage, pharmacy, outpatient. Diapers, pharmacy, outpatient. Briefs, pull-ups, pharmacy, outpatient. Bed pads, pharmacy, outpatient. Urinal, prosthetics, pessaries, referral may be needed for fitting, prosthetics. Perineal cleanser, pharmacy, outpatient. Petroleum-based ointment, pharmacy, outpatient. Zinc-based ointment, pharmacy, outpatient. A&D ointment, pharmacy, outpatient.
This next page shows you kind of, ends up being about a 3x5 card that the clinician can actually place at their workstation or in their clinical exam room to, again, give them some reminders of some of the products that are available through the VA pharmacy to try to provide containment and skincare support for patients who are experiencing urinary symptoms that, again, is a little bit unique to the VA system. And we sometimes find that clinicians are not always aware of all of the options that are available to them to, again, reduce some of the out-of-pocket expenses for our patients. So this is one side of this handout. And I think if we click once more, we'll go to the other side of it.
Common diagnosis, ICD-10 code, stress UIN 39.3, Urger UIN 39.41, mixed UIN 39.46, overactive bladder N32.81, Nicturia R35.1, nocturnal enuresis N39.44, incontinence without sensory awareness N39.42, 2-column table of medication and dosages, VA approved, oxybutynin, first line, 5 to 20 milligrams DXL formulation, double asterisk, 2.5 to 5 milligrams Q6-12H, IR formulation, 3.9 milligrams 24-hour, apply patch 2x week, double asterisk, available OTC, not VA formulary, tiltaridine, 1 to 2 milligrams Q12H, 2 to 4 milligrams DLA formulation, double asterisk, trospium, 20 milligrams Q12 to 24H, on empty stomach, 20 milligrams D if age greater than 75 years, 60 milligrams DXR formulation, not VA formulary, sulfenacin, 5 to 10 milligrams day, mirabegrin, asterisk, 25 to 50 milligrams D vaginal estrogen cream. Indication for atrophic vaginitis, pharmacy outpatient, available but not approved. Darafenacin, 7.5 to 15 milligrams D fesoteridine, 4 to 8 milligrams D vibegrin, 5 to 10 milligrams D single asterisk preferred agent when anticholinergic medication is contraindicated, double asterisk associated with fewer side effects than IR formulation.
Which again includes the ICD-10 codes for some of the most common urinary symptoms. This coding allows us to also track new diagnoses again, through our clinical data warehouse partners. And then this is an example of some of the drug-based treatments, again, if the clinician and patient think that's the best route to go, so that they have some idea of what the formulary options are within the VA system, as well as, I mean, you can even see here just some brief dosing guidance, even to try to optimize the dosing, particularly for older adults, for instance, who might be considering this with their clinician partner. Okay. So
Successes and challenges. Direct outreach to women veterans yields more interest in treatment than relying only on consults from PCPs. Added staff effort to outreach to veterans via mail, snail mail, and secure messaging through health record.
So some of the considerations in kind of the rollout of these resources, we have seen nearly 800 women veterans who have opted to complete that online My Healthy Bladder questionnaire, which is really exciting to see the uptake of that option, again, for kind of self-referral. We have also found, and this is maybe one of the things that in considering, you know, what we're going to learn from all these projects, that the direct outreach to women veterans in the that are assigned to the clinics that we have targeted or have already started enrolling in the Pursuit program does require some additional staff time to either send an electronic message through our secure messaging platform, which is called My Healthy Vet, or to actually mail those flyers out to women veterans. So I think that's one thing that, you know, I think we've seen some uptake, a greater uptake of the program with that direct to patient outreach, but it does take some additional effort that we're doing at this point on behalf of those clinics. And so I think that's going to be one of the lessons learned as well. And then we, again, have found that I think the providers do appreciate having some of those common diagnosis codes kind of just available at the time that they're completing encounters or completing their documentation during a visit. And some of these, you know, they may have a couple that they frequently use, but it does help us get a little more information on the kind of back end of more specificity of diagnoses by providing some of those most common ones so that they know what they are at the time that they're entering that information. Again, the clinician resources try to highlight some of those unique availability of particularly some of the containment and skincare products that are available through the VA pharmacy, which is not common in a lot of non-VA healthcare options. And then we've generally found it, again, providing a lot of different ways that a patient could access the programs that, again, would allow self-referral seems to be welcome. And we'll have more information about users of that, of kind of, you know, that have done the self-referral kind of pathway to kind of maybe to learn more about characteristics of those veterans, what were some of the, you know, some of the information about why they may have selected to do that versus kind of go through the traditional consult route. And that's part of our evaluation to come. Thanks so much.
Thank you so much, Camille. All right, we are now moving into our IT2 team. We have two more teams to present. And presenting for IT2 will be Dr. Stephen Purcell. Here we go.
Implementing automated patient questionnaires, IT2 team. Stephen D. Purcell, MD, MPH, Professor of Medicine, Feinberg School of Medicine, Northwestern University.
Great to be with everybody today, and thanks for inviting us. And I'll be speaking on behalf of the entire IT2 team, which includes my MPI, Kim Kenton, at the University of Chicago, and others at Northwestern and Northwestern Medicine. And I'm mostly going to be speaking about a specific technical implementation of automated patient questionnaires that we did as part of our project, which is really kind of an essential piece. But I'll also have time to talk briefly about the interactive educational module, which we connect our patients to directly. You can go to the next slide. So our goal is to implement in a large regional health system, which is Northwestern Medicine, system-wide screening for urinary incontinence in women in primary care, followed by automated access to an online educational interactive module about urinary incontinence and its treatments. And so this is a collaboration between urogynecology. I'm a primary care general internist. We also have family medicine in Northwestern Medicine, and also the clinical quality groups, information technology, analytics, and program management. And our target population here is really all women 18 years of age and older seeking routine ambulatory primary preventive care services. And so our big components and big buckets are routine screening embedded in practice for annual and preventive care visits, access to an interactive online educational module about urinary incontinence subtypes and its treatment, that also elicits patient preferences and also prior things tried, and then other clinician point of care resources and decision support for our treating clinicians. You can go to the next slide. So we really felt that to start this off, we had to hardwire the Women's Preventive Health Initiative recommendation to actually screen in preventive care visits for all adult women. And then we had to make reliable workflows so that we would actually accomplish that. And the advantages of an automated patient questionnaire are actually quite a number of them. In our current system, we already used automated pre-visit contact occurring approximately 3 days before a patient's visit to perform registration tasks and to deliver other questionnaires and clinical content. If patients are willing to do this, it gets done before the office visit, which doesn't require clinician and staff time during the office visit. And then in our specific project's workflow, it also enabled us to direct patients to learn more about their own type of urinary incontinence and the treatment options available for it by doing pre-visit work with this online educational component, which I'll show you a little bit about. And then the other thing that we don't really know the answer to yet, and we probably won't be exactly designed to solve this question, but we're seeing early evidence that there may be more willingness to disclose bothersome symptoms on an automated pre-visit questionnaire than there are during an in-person, being asked the question in person.
IT2 implementation strategy flow chart. First, women schedule wellness/preventive visit. Then, the automated pre-visit questionnaire is completed. If it is completed, WiserCare UI module is sent pre-visit for positive screen. If response is no, screen during rooming or visit, then WiserCare module is available post-visit for positive screen. Upon positive response, module offered to my chart users and clinician alerted to address.
So this is the basic strategy. A person scheduled a visit 3 days before the visit, they'd be sent the option to complete a pre-visit questionnaire via the patient portal. Currently, this group of patients has a very high uptake of having the patient portal. Doesn't mean everybody will use the portal, but greater than 90% of patients have the portal. And then if the patient either doesn't use the portal or doesn't respond to the questionnaire prior to the visit, to be able to ask the screening question during the rooming process. And for patients who do answer our single item screener, to be able to direct them to this interactive module. And that could occur before the visit or after the visit. And then we also, I'll take you through the steps of what that entails next. You can go to the next slide.
Screenshots patient display, copyright Epic Systems Corporation.
So here's one of the co-investigators pretending to be a patient of mine for a new patient annual exam. This is what the actual registration system looks like. You would get a request to open your MyChart portal, check in, put in your demographics, check your insurance and other contact information. And then if you had been assigned a questionnaire, which this is one of, view the questionnaire. And here we asked a single question, which was trying to explain to people that bothersome leakage of urine is very common. And do you have bothersome leakage of urine? And the response options being yes, and I would like to learn about possible treatments. And that response is what triggers the downstream invitation to do this online interactive module. We also capture when patients report symptoms, but either are already receiving care or are not interested in learning more right now, or of course they can say they don't have the symptoms. Once that happens, you can go to the next slide.
Screenshots clinician display. Copyright Epic Systems Corporation. PT entered questionnaires tab is selected. Current view. Showing only relevant answers. Table of questions and dated responses. Best practice tab close up. Patient response when asked, do you have bothersome urinary incontinence? Yes, and I would like to learn about possible treatments.
It's very important, if this is a part of a real workflow, that the clinician seeing the patient actually gets the results of their questionnaires. So we actually have a couple of ways that we can put that up in front of the patient, up in front of the clinician. So there's a place that all the responses live. And so again, when working in a system that is using pre-visit automated questionnaires for a variety of things, here you see depression screening, here you see social health-related social needs screening. We've also done fall screening for older patients. You can see all the responses given, but also the ability to actually trigger a more lit up alert for patients who actually report a positive result. And so here's an example of an alert that would trigger to the physician during the primary care visit if the patient had said that they had bothersome urinary incontinence and would like to learn more about possible treatments. If that patient had already done the interactive module and completed it, this hyperlink at the bottom would be available through that hyperlink to see I'll show you about Wiser Care, what Wiser Care is in a moment.
Successes. Uptake by patients is high. Of initial 4589 patients eligible for screening, 3871, 84%, completed screening. 2523, 65% of screenings done with pre-visit questionnaire. 1348, 35% were screened in the office. Questionnaire respondents more likely to indicate help wanted. 13.2% of pre-visit questionnaire respondents indicated they had bothersome UI and wanted help. 6.8% of office screening respondents indicated bothersome UI and wanted help.
So, ultimately, the successes of the pre-visit questionnaire have been quite high so far. And this data is already a little bit old, but of over 4,500 patients who were eligible for screening, meaning that they had one of the targeted visit types, 84% of them completed screening, and almost 2/3 of this was done using the pre-visit questionnaire, and 35% was done in the office. And so that means 2/3 of the time patients coming in have already answered the question, and we already have it done, which we thought was a really wonderful uptake. And this is about 5 practices so far that's depicted in this data. And then the other thing we're seeing is a much higher rate of people responding that they have bothersome UI and want help with it, with a response rate on that of 13.2%, compared to fewer than 7% saying the same thing when they're asked directly by a medical assistant. So I think that if others are interested in using pre-visit questionnaires, I think it's important to understand the context of the office or system. How are they currently using them? How would this fit into work that's already being done? I think that when it's part of something that patients are already used to seeing when they're going to the doctor, the uptake is going to be greater because it's already part of what they're used to doing. This is governed by certain folks in informatics and primary care. We have to figure out who those folks are and work with them to actually fit this into their existing processes. And you have to work very closely with your IT group. And I think this was the hardest piece, working within resource constraints. We fortunately had a group with great capabilities, so they were able to solve technical problems that occurred. Even determining which group of patients to send this to was not trivial. I think we initially thought that legal sex would be a sufficient variable to determine who got this got this instrument, but we actually tried to make it a little bit more tailored because that wasn't that was sending to some patients who might not actually identify as women, and we thought that our clinical content wasn't right for that group. So we had to use a complicated logic to actually deliver this to the right patients. And we also had to know exactly which types of visits we were targeting, because you can't wait till after the visit to see, was this an annual visit? You have to know as it's being scheduled. Again, you have, as I showed you, you have to have a workflow available to actually get the results in front of the physician who's going to see the patient or the other clinicians. And then, getting frontline user input and responding to it was important as we first rolled this out in our early practice. And then communicating this to both the clinician users, the rooming staff, and others, our other aspects of how we implemented this. You can go to the next slide.
Northwestern Medicine Primary Care and Wiser Care Partnership. What is Wiser Care? Digital software partner who has developed an online patient-clinician program that provides education for urgent stress urinary incontinence, then provides best fit for treatment options based on patient feedback, preferences, and clinical guidelines. How does Wiser Care help patients and clinicians? Helps prepare the patient for the upcoming visit through education about urinary incontinence, offering care options to consider along with personal preferences for care prior to the clinician appointment. Provides the clinician with a patient-centric report electronically filed into the patient's medical record. This streamlines urinary incontinence discussion at the point of care, allowing for efficient focus on next steps in care.
And so a little bit, I'll just talk very briefly about our interactive module that grew out of a partnership with our urogynecology group and a knowledge vendor in Southern California called Wiser Care. And they had already partnered with them to actually give patients who are considering either subspecialty care for urinary incontinence or subspecialty care for pelvic organ prolapse, this type of tool to actually educate them about treatment options. And so in the first part of our project, we work with that group to adapt this for a primary care suitable group. And what it really does is it provides education and elicits questions about the type of incontinence, asks patients about treatments that they've tried before, asks them about potential pros and cons of those treatments, and lets them suggest enter their preference for different types. And this is backed up with lots of evidence-based knowledge that was incorporated into these algorithms. And so then patients get a report back ahead of time that shows, this is what I've done, this is what I might want to try next based on my responses, this is the type of urinary incontinence that I likely have. And then an abbreviated version of that files back into the electronic health record so that the primary care clinician can use it with a patient making treatment decisions. And I think on the next slide,
what does Wiser Care look like? Example page and module. Screenshot urinary incontinence treatment options online experience introduction screen.
This shows you the different types of modules that this workflow takes patients through. It first gives them information about urinary incontinence. It asks specific health questions to try to identify the type of incontinence, asks about preferences, and presents treatment options. And the way we also set it up is that people could stop after, if they really weren't interested in options that required subspecialty referral, and focus on primary care, appropriate treatment options, or learn about a wider range of treatment options. And you can see the next slide is an example of the report that the clinician might get back.
Screenshot urinary incontinence provider report,
which says basically that this person's symptoms are consistent with stress incontinence. They've already tried these things, and based on their preferences and the way they answer their questions, it seems like the treatments right now that are most consistent with their preferences are to do pelvic floor physical therapy, bladder retraining, and lifestyle changes. And if they responded differently, then it would suggest something else. And so that's what we have for right now.
All right, thank you so much. We are now moving to our final presentation from the teams before we open it up for Q&A. And I have seen a lot of great stuff coming in through the Q&A window and would just like to take this moment to encourage folks. We are capturing those questions as they come, and we plan to elevate them to the speakers when we get to that point. So please continue doing so. We appreciate your sharing all of that with us. We're not losing any of it. And so without further ado, I will now turn it over to the Optima team and Jennifer Anger. Thank you.
Clinical Decision Support Tools, OPTIMA Team, Jennifer Anger MD, MPH UC San Diego Health, Cedars-Sinai, UCLA Health, Harbor UCLA Medical Center, EvidenceNOW.
Thanks so much. Can you hear me?
Yep, all good.
Okay, great. Okay, we can go to the next slide, please.
Optima Overview. We previously developed and pilot-tested a set of patient-centered evidence-based quality of care indicators, QIS, for urinary incontinence, UI, and found a measurable deficit in the level of the quality of care provided for UI. We seek to perform a practice-based intervention to improve the quality of care for women with UI at the primary care level and reduce such deficits in care via a four-pronged approach.
So our study is based out of Southern California, 4 sites. And our goal is to improve quality of care for urinary incontinence at the primary care provider level. So in a nutshell, it's we compare usual care versus a combination of academic detailing, which is a 15-minute lecture on incontinence, clinical decision support tools, and that's going to be the focus of what I'm going to talk to you about today. And then the option of referring to an APP or advanced practice provider. So what is that? That could be a midwife. It's usually a PA, physician assistant, or a nurse practitioner who can then spend time with the patient on the patient-facing piece, like behavior modification, Kegel exercises, fluid restriction. And then we have an electronic referral mechanism where we will get referrals to us as specialists, but then maybe possibly return them back and say, hey, do you want to try medication first? Because what we found is our primary docs are great at managing incontinence, but they tend to stop before they prescribe medication. That seems to be a little bit of a barrier to where they don't get that. They're a little uncomfortable. Next slide.
Specific aims. 1. To improve the quality of incontinence care provided to an ethnically diverse population of women through a control practice-based intervention involving generalists. 2. To determine if this intervention decreases utilization of specialty care. 3A. To measure the effect on patient outcomes including symptom severity, disease-specific quality of life, patient knowledge, and perceived shared decision-making. 3B. To determine if a practice-based urinary incontinence intervention reduces variation and disparities in care.
So our goals are: 1, can we improve quality? So we will, after we meet with the providers, we actually do a one-on-one feedback based on some prior care that they've given. And then we will screen patients and then over 6 months, see if the providers in the intervention group gave better care. So that's by us looking at the charts. Can we reduce the use of a specialist if the primary care doc gives better care? And then can we actually improve outcomes, patient incontinence outcomes, and also if there are disparities in care based on race, based on provider gender. We found that women doctors tend to do a little better based on patient ethnicity, patient, even area code, those sort of things. Can we actually, by intervening in this way, can we reduce potential barriers or disparities in care? Next slide, please.
Project Team Flow Chart. Leadership Team. Jennifer Anger, MD, PI Jehokula, MD, Head of DCC Florin Vita, PhD, Statistics-Led UCSD. Leadership, Marlene Millen, MD. Clinical Champion Team. Mingtai Seal, PhD, Primary Care. Marlene Millen, MD, Primary Care. Jennifer Anger, MD, Urology. Informatics, Jehokula, MD, MPH. UCLA Leadership, Janet Priegler, MD. Clinical Champion Team, David Rubin, MD. Primary Care/Geriatrics, Neil Wenger, MD, MPH, Internal Med. Tamar Grisales, MD. Urigen. Informatics, Jennifer Singer, MD. UCLA Health. Cedars-Sinai Leadership, Carolyn Goldsweig, MD, Clinical Champion Team, Allison Mays, MD, Primary Care/Geriatrics, Cedars-Sinai, Kimberly Gregory, MD, MPH, Allison Mays, MD, Harbor, UCLA Leadership, Catherine Ward, MD, Clinical Champion Team, Carmen Mendez, MD, Primary Care, Catherine Ward, MD, Primary Care, Taznuz Tazdani, MD, Urigen, Informatics, Rami Eskander, UCSD flows to UC San Diego ACTRIDISC, Dissemination, and Corey. UCLA flows to AHRQ and CTSI Cedars-Sinai flows to CTSI and CERP Harbor. UCLA flows to CERP and NAFC. 125 provider participants per site. 500 total provider participants.
So this is just showing our team. It's based out of Los Angeles and San Diego, including a public hospital, which is Harbor UCLA, and also San Diego Hospital Care System also has a public element. Cedars-Sinai and also UCLA. Next slide, please.
Implementation need. Many patients do not discuss UI with their primary care provider, PCP, due to embarrassment and stigma. Assessment of UI in women 65 and older is now a Medicare quality measure, and the Women's Preventative Services Initiative recommends annual screening for UI in women. Self-administered electronic surveys can provide efficient screening of UI. However, there needs to be an effective mechanism for alerting PCPs of patients that screen positive. Implementation need. In a pilot study, a mechanism consisting of a combination of email and electronic health record (EHR) message only prompted the discussion about UI in 21% of visits. We developed a pop-up clinical decision support (CDS) alert that is timed to occur on the day of the appointment.
So what's our goal? We found that interestingly, patients don't talk to their providers about incontinence even when it's bothersome. And as we all know, I don't need to tell this group that we know that screening is a Medicare star measure, and we're looking at, we want to, because screening is becoming implemented, we want to be able to provide doctors with the ability to handle a positive screen. What can they do? How are they comfortable managing it? And interestingly, in our pilot, which was at Cedars-Sinai, this was before we applied for this grant, when we screen patients for bothersome incontinence using email actually, and found that of those who participated and were had bothersome incontinence, so not just incontinence but bothersome incontinence, only we would then, so patients were bothered and we alerted the providers that their patients were bothered. How do we do that? We emailed them and we reached out to them on Epic. But even in that case, only 20% of the patients who were bothered actually had the conversation with their provider about it. So here we seek to how can we fix that piece? Because we can't, our tools are only so good if there's no conversation happening between the provider and the patient. So we want to show you this pop-up we developed, which actually we just submitted an abstract to our urology meeting, because this pop-up actually made a big impact. Either that or it's a small sample size, but I think it really increased the number of conversations occurring from this 21% to upwards of 70%. That's 70. So we're really excited. Next slide.
Pop-up CDS features. Pop-up CDS alert built in Epic Systems EHR as a best practice advisory, BPA. Control and intervention BPA. Dynamically displays based on PCP randomization assignment. Intervention BPA contains a button linking the PCP to the order set and other CDS tools, timed to occur on the day of the appointment. Defer acknowledgement button allows PCP to defer discussion about UI to a later visit if there are more pressing medical issues to address.
So what we did was a BPA, a best practice advisory. When the doctor is opening the chart, when the patient's in the clinic, this best practice alert pops up kind of in their face. And these are hard to do because a lot of the time, our IT leadership don't like best practice alerts because they can be very annoying to providers. But we were able to get this through because it was considered to be minimally annoying and also maximally important. And so we were able to get this approved at our hospital. So go ahead and go, and the doctors can defer it if they don't want to manage incontinence. Next slide, please.
Screenshots best practice advisories for control and intervention BPA.
So here, this shows you to the left that it pops up. That's the best practice alert saying your patient is screened for bothersome incontinence, and the doctor can say, we'll discuss it, or they can defer it. And then so in our control and intervention, we have to have the BPA for both groups, but the intervention actually will then provide a link to these tools that help the provider manage the incontinence. So we have a whole list of meds, which is designed to help them feel more comfortable managing meds, different orders, urinalysis, even provide so all these other clinical decision support tools are linked with this BPA. Next slide, please.
Pop-up CDS development. We examine multiple tools to communicate positive screens to providers, including emails, Epic and Basket messages, secure chats, and BPAs. Primary care leaders, informaticists, and CDS committees across 4 Southern California sites were consulted on build feasibility, provider utility, adherence to local policies, BPA pilot tested and further refined, additional restrictions placed so it would not fire for rooming staff.
And so what we did here was we worked with our primary care leadership at these 4 sites and actually made different pop-ups that were feasible for each of the sites. And then we tested it and found, for example, one time it fired on when a medical student opened it. So we had to make some tweaks so that it would be only fire when that primary care doc opened the chart to see the patient. Next slide.
Successes and challenges. Our BPA facilitated a discussion about UI in 20 of 28, 71% of primary care appointments at one of our U18 sites. This rate was compared to the rate from our pilot study at Cedars-Sinai, 35 of 166, 21%, where PCPs were notified of patients that screened positive via email and error message. A chi-square test with continuity correction determined a statistical difference between groups, p less than 0.001. BPA is an effective mechanism for promoting a discussion of UI.
So again, 71% of patients with bothersome incontinence had the conversation because we attribute it to this BPA because it's such a big difference. And I think because we often need reminding as providers to be able, if it's in your face, like your patient has incontinence, and you'll be like, okay, now I'm going to remember. And that, because it's, if you put it up to the patient, the patient is often embarrassed to bring it up. And so it really should, I think, be on the part of the provider. And then this actually was statistically significant. Next slide, please.
Uptake considerations. Increasingly difficult to get interruptive CDS approved for system-wide implementation. Interruptive alert fatigue. Signal-to-noise ratio. Current bill requires manual person input to tell the EHR to fire the interruptive alert for a particular patient.
And so, and as I briefly mentioned, that clinical decision support, luckily at UC San Diego and actually all the sites, we've had a lot of I have a great our informaticist on our team, Gijo Kula, is really great about getting things done and supporting this. So we've had a lot of buy-in in primary care in allowing us to make these tools, which is really, really been helpful. And I think that's it. Next slide. All right. Thank you.
Moderated Q&A.
Thank you. All right. I want to just do a quick thank you to all of our speakers today, and to all of you who have been attending. I've seen some good questions coming in, and I think before we move to Q&A, we just wanted to highlight a few resources for all of you. So let's go to the next slide. There we go.
Access implementation tools. Resources available at https://www.ahrq.gov/evidence-now/projects/urinary/resources.html, Wisconsin Intuit, UI Practice Launch Toolkit, Pursuit, Patient Recruitment Flyer, Clinician Pocket Guide, IT2, Clinician Education Module, UCSD Clinical Decision Support Tools, UI Pocket Guide, Academic Detailing Videos, Empower, Interactive UI Care Pathway Tool, Sustainability Menu.
All right, so here we have everything that you heard about today, and then there are actually a couple of extra resources noted in there as well. All of these resources are going to be available on AHRQ's website. They are to come, so we have contact information for you all for having participated in this webinar, and we I believe we'll be asking in our follow-up survey if you are interested in getting a notification that these have been posted. They will be posted in the coming weeks, and we look forward to sharing all of these resources with you. So everything you saw today, plus a few additional items, will be made available on AHRQ's website. And I think the link is available in the slides. We'll also be sharing it with all of you in follow-up as well. All right, let's open it up for Q&A. I think it's been pretty lively. I've seen some great questions coming in. So maybe we can move to the tiles so that we can see all of our speakers. And if all of our speakers could come back on camera, that would be fantastic. And then my colleague Sarah Hoyt and I will be pulling questions from the chat for all of you. And thank you to those who have been responding to some of the questions in written form. So some of you who have submitted your questions, you'll find answers in the Q&A box as well from our speakers. And others, I think we're going to go ahead and elevate here. So let's start with a question. You know, I'll be honest, I've seen a couple of questions come in that are all kind of getting at equity issues, right? And making sure, how are you in your projects, making sure that you're not potentially exacerbating disparities or leaving them the same, right? In what way is your work advancing equity? And so maybe I'll just do kind of a round robin. And so maybe we'll start with Heidi in Wisconsin, but we'll come around to each of the teams to hear about that.
Hi, thanks so much. It's a really important question. And the truth is that almost all implementation research is happening, has the potential to exacerbate disparities because we're implementing with the folks who are already receiving care and connected with healthcare systems. We are, in our work, we are intentionally enrolling clinics that have sort of fewer resources, and that's a way to reach small groups of folks. But in truth, in general, implementation research is tough because we start with systems that are already working well. And especially when we're doing things through primary care, we're implementing interventions with folks who've already got primary care. So inevitably, we are exacerbating some disparities.
Elizabeth Cope.
Thank you, Heidi. Let's come to Steve and IT2.
Stephen Purcell.
Yeah, no, I think it's a great question. And I think the first thing that we want to make sure is what's happening even in the group that we are delivering care to. And we have to measure this and see if the downstream processes are actually similar for different groups, including groups that don't have access to some of the tools that we have. I think so we're actually looking at, there are the actual treatment recommendations or orders that come out of these interactions occur whether or not people use the interactive online module. So it's like, how are those going to be different by different types of users? That's going to be a very important question. I think that the difficult thing about you doing things that rely on technology is there's always a group that's going to have less access to that technology. One thing that we hope is that by actually, if we think about the primary care office's work as a whole, and we do some things that can enable that work to take place outside of the office, then the folks who need to do it in the office actually have enough time to do it in the office. That's an empirical question that we want to examine.
Elizabeth Cope.
Great, thank you. I'm going to come to Elisar, who is representing Empower on behalf of Adonis at this time.
Hi, yes, I believe that for the Empower group, we've primarily been utilizing our resources by nurse navigation, which in terms of equity and inclusion, those nurses are getting patients from all over of different socioeconomic backgrounds, as well as racial backgrounds, because of how far-reaching the project is itself, which also comes with some barriers in terms of technology, because our project and many of the other ones are also virtual based and computer based. That does introduce a technology barrier, but outside of that, we've made all of our treatment options and the UI care pathway that we had discussed previously in this presentation, which is completely provider focused or continence advisor focused. So it is on the person who is handling the pathway to provide resources in a way that is digestible by the patient. Our nurse navigators also work very closely with problem solving in this way. It is very difficult to see all of the patients who have technological issues to begin with, and we kind of have to like problem solve throughout all of that. So that's why our training with our UI care pathway does occur by training of our nurse navigators. They provide all of the tips and tricks of how to better serve the populations.
Elizabeth Cope.
Great, thank you, Elisar. Let me come to Camille.
Camille Vaughn.
Yeah, thanks so much. It's a really, really important question. I think within the VA health system, I mean, we are often serving a lower resourced population. And so it is really important to know, I mean, many veterans who are going to qualify for VA healthcare, you know, that is kind of the their safety net in some ways. We are, you know, of course, the My Healthy Bladder application for veterans that are going to use that is going to be, you know, require someone who kind of has that ability to access internet, be on a laptop or a computer or a mobile health device, you know, a mobile device of some type, either a tablet or, you know, a smartphone type device. But that is not the only type of treatment available through VA. They can, you know, certainly be referred to a continence specialist at one of our centers. They can, we do have video telehealth through a VA platform available for some that can access that. And even for veterans that would prefer video telehealth who don't have the infrastructure or don't have a device, VA actually will provide a tablet and internet provider for that particular device as well. That goes through the social worker at their clinic, as well as another type of video telehealth option at their outpatient clinic that connects to a specialty continence provider. Not all of the clinics have that, but some do that we serve. So it is not a perfect answer with all options available for everyone, but we do try to reach patients in multiple different platforms and strategies to reach as many people as we can. And I think, again, we will be learning through this program, which is part of the implementation, you know, evaluation. That's really the key part of what we're doing, you know, what those barriers look like for the populations that we're serving across the country. So it's a really important question, and we're going to know more because of this project.
Elizabeth Cope.
Great, thank you. And last but certainly not least, I'll come to Jennifer.
Jennifer Anger.
So I love this topic. So the first thing we did was we translated all our, well, a lot of them were already translated and validated, but all our questionnaire tools are in Spanish. We actually developed our own like knowledge survey, and then we validated it in Spanish as well. And then for our underserved populations, largely Spanish speakers that don't have email, we just have a bilingual RA who calls them and just gives them the surveys and consents over the phone. And then for they just have to sign consent in person when they come for the visit. So that's sort of those have been our main strategies, I think, in reducing disparities.
Great, thank you, everyone. I am going to pass to my colleague Sarah for our next question.
Sarah Hoyt.
Elizabeth. We've had a couple of questions that are getting at patient engagement and provider engagement. So just wanted to ask the group, to what extent has patient and provider input been sought during the development of these resources? Maybe we can start with Steve.
Stephen Purcell.
Yeah, so we've gotten, early on, we had a patient focus group engaged around the development of this content and approach, and also clinician users, in the earliest practices. So I would say it's very important to get both patient and clinician user input and MA input into the design and early implementation.
Sarah Hoyt.
Great, thank you. Heidi, do you have thoughts?
Heidi Brown.
We did not solicit feedback from patients for the materials in our toolkit because our audience is practices, but we sought a lot of feedback from participating practices and have done iterative revisions for them. The patient-facing materials that we've offered for practices to use are developed by the American Urogynecologic Society, which partners with patients to create those educational materials.
Sarah Hoyt.
Great, thank you so much. Camille?
Camille Vaughn.
Yes, we had a kind of a preliminary project before Pursuit was selected that led to the development of like the My Healthy Bladder application and some of the patient-facing resources prior to the Pursuit project being selected for this. So that definitely gave us some feedback from users of the My Healthy Bladder platform. In the development of some of the provider-facing resources, that was vetted as they were in development with some of our continence clinic colleagues at the Birmingham and Atlanta VA clinics who were not directly involved in the project, but also have kind of awareness of some of the common things that come from clinicians who are consulting our services, as well as what would be user-friendly. We do have the opportunity as we move forward, though, through this project to tweak things. And so, our first sites that enrolled, definitely we're looking for some feedback from them as we kind of did some clarifying, I guess, of some of the resources, as well as some user guides for some of the like the dashboard we just talked about on the last webinar. So there are opportunities to kind of make some adjustments as we go forward, which is the terrific part of an implementation kind of hybrid QI project versus our traditional, randomized controlled trial with a protocol that's very difficult to change. So that's a really great question. And it's really important that we kind of have our users in mind for all of these resources.
Sarah Hoyt.
Thank you so much, Camille. And Elisar from the Empower team, I believe you.
Yeah.
Elisar Kawam.
Yeah, and I apologize, my video's off. I'm hoping it helps with connectivity issues. So just stop me if you can't hear me, but our team was actually extremely lucky. We have implemented our project out in waves, and because it was implemented in waves, each wave we were able to take feedback from patient-facing materials and marketing materials and kind of edit those to better reach the public. So that's kind of how we've been changing our current materials throughout the entire project phase. Before the implementation of the project itself, we did have our PIs seek feedback from institutional leadership as to how we should attack this issue on an institutional level. So everything was really built around feedback from other physicians. And we also had patient-focused control groups from a urology clinic that saw patient-facing materials before we made them live. And then looking forward into sustainability, we did have some feedback from the practices that were involved in our projects in waves 1 and 2. But we also utilize feedback from something called a study advisory group, which is a collaborative group where we talk about diversity and project struggles with a nice variety of members, including patients, which provide us with additional feedback for things like patient resources, sustainability options for practices, etc.
Sarah Hoyt.
Great. Thank you so much, Elisar. I will throw it back to my colleague Elizabeth for our next question.
Elizabeth Cope.
Thanks, Sarah. So I think I would like to ask, because we've heard so much about all of these different tools today. So just wanted to get a sense from folks, and I know that you shared a little bit in your presentations, but in thinking about how these tools might extend to other practices, if you'd been hearing things from the folks that you've been working with so far and rolling out these resources, that might inform what you would advise or tell others who would be interested in taking these tools on themselves. So what can you share related to uptake in other settings, and what have you been hearing from those that you've been working with that might inform those activities? And maybe I will start with Camille.
Yeah, thanks so much. I mean, I think one of the things I kind of highlighted as a potential challenge that from our experience so far is that we are finding there are a certain number of, our population who are not discussing this with their clinical teams and maybe have some stigma, or I don't know, they're shy about it, or maybe they don't have that connection with their clinician to want to have that discussion with them. And so I do think having these options for some sort of self referral is going to prove to be a unique contribution. The thing is that I think it's a little challenging for our healthcare system is that, we are doing some of that outreach on behalf of the clinical teams, right? So these are some extra. So it's going to take a commitment from a health system to devote some resources to that type of outreach. It doesn't necessarily have to be forever, but if you're going to choose to really highlight this area, it may be that just thinking about what the resource needs of that health system or program to make sure that you're really making those resources available to everyone, even if it's not. And again, it could be some way that allows the self-referral. I think it's easier these days with the portals and things that people are using, so they can have more control over letting their clinical team know their preferences, or potentially again accessing things without needing a consult, where you have to kind of put that formal request in and wait for someone to respond. I think one thing that's exciting, I mean, in our program and probably some of the others too, our kind of continence specialty group is pretty well known locally, but because of this, we have opportunities to extend services to clinics that maybe haven't had this type of continence specialty care that's really, again, pursuing kind of initially non-surgical based treatments. And in those clinics, we see a lot of enthusiasm. So that's a really good thing when you're trying to implement something in primary care, is that it is perceived as an important problem. The clinicians are excited about having options available to offer their patients. And it makes it easier for us to encourage doing something about it. So I think I'm finding even more enthusiasm in some level in our new sites that haven't already had a consult available to them or knew about the My Healthy Bladder program. So that's a good thing.
Elizabeth Cope.
Yeah, no, that's wonderful. Maybe I will go to, let's see, Jennifer, just to hear a little bit more about reception of the tools that you guys are rolling out?
Kyle Lakamuro.
Yeah, I think
Or
I'll
sorry, Kyle.
field the question. Yeah. Hi everyone. I'm Kyle. I'm the research project manager from UCSD Optima. Yeah, and something that we did for the clinical decision support tools was we specifically built them at a health systems level. And so there were like additional upfront governance considerations and approvals that we needed, but we were sort of able to get approval to build it at a systems level, and we all we did was place certain restrictions so that the tools are only accessible, at least for this duration of the study period, to our study providers. But I think that once the study is over and we're hoping to roll the intervention or the tools that we built across the health system, it'll be relatively simple to just remove those restrictions. And you know, in terms of uptake, the tools are there already in the system for our PCPs to use. You know, another aspect of our intervention is this sort of e-referral system, which is almost kind of like a e-consult type of referral type. And so something that we're also exploring as well is sort of piggybacking off of you know, at some health institutions like UCSD, UCLA, and Cedars, there's kind of already new, like there's sort of system-wide implementation of like formal e-consults, and perhaps like piggybacking off of those efforts, and then just developing kind of like a UI e-consult type referral mechanism is something that we're hoping to take advantage of.
Sarah Hoyt.
Great, thank you so much. Let me come to Heidi.
Heidi Brown.
I'm sorry, can you remind me the question?
Elizabeth Cope.
I sure can. So yes, we were talking about how, as you've rolled out the resources and tools that you were sharing about today, what has been the reception, and what might that, how might that inform other practices that are listening to this webinar today and they're thinking about taking up these tools?
Heidi Brown.
I think the reception has been pretty positive, in part because when people tell us that something isn't right, then we are tweaking it so that it's more right the next time around. What we're doing is the sort of basic approach to our project is we've found that in these very diverse practice settings, everybody is screening for and managing depression pretty well. They have that workflow outlined. And so early on in our process, we sort of like ask how they do that, and then we sort of direct them to the materials within our toolkit that would align with the way that they're doing screening for and treating depression. And we're not as focused on exactly how they're managing the incontinence. We provide support for, you know, like how they might manage it. But I think we've realized that incontinence is not going to be like, nobody's going to want to go to a separate website for incontinence materials. Like, this is like, already we're asking busy primary care practices to do something that is probably going to add time rather than save time, unless we have it really streamlined. And so we're kind of starting with depression screening, and I think that's a takeaway that would be helpful for other folks trying to do this, you know, without the support of a funded research study. Is if you want to try to hit urinary incontinence screening out of the park, like, pick whatever other condition you've already nailed down a process that works for your context for screening, and, you know, implement a similar process with PDSA cycles for incontinence. So that's the reception is like, I mean, we're preaching to the converted, right? They enrolled in our research study. So the folks who don't want to do it are not going to are not going to enroll in our study. But we have found that people are actually enthusiastic for ways, like incontinence is a doorknob question that really is annoying at the end of a busy visit. So if they've already got some sort of resources at the tip of their fingertips from this, that is time saving and helpful.
Elizabeth Cope.
Great, thanks, Heidi. Steve.
Stephen Purcell.
Yeah, and I'd say that a lot of the questions that practices ask us when we are trying to implement is what's the access to a pelvic floor physical therapist? What's the access to a subspecialist? And, I think that we try to address those questions, but, the more practices that come online, the worse those access issues are going to become in our region. We do hand out a whole list of independent therapists in addition to the ones within our system. There are many outside our system. I think I'm really looking forward to potentially adopting some things from others in this group, because to be able to give people more about what can I do now before I can access that specialist or that physical therapist. What are the first things that I can do? What are the things, how do we guide primary care clinicians to be able to do more of that coaching? We're trying to do that, but I think there's room to improve it, because I think right now people's workflows are often really orienting people away from going to the subspecialist before going to the pelvic floor physical therapist, I think is kind of a practice change for a lot of PCPs. So access is really important, but I think we really need this, like, what can I do from day one to start to address this, even if I don't have access?
Elizabeth Cope.
Thanks so much. I'm going to come to Elisa. We're going to squeeze you right in at the end.
Elisa Column.
Yeah, sure. So with our project, it's interesting. Most of our tools that we're providing are sustainability tools. So what can we provide to providers and patients once Empower is gone? And we provide a ton of information and statistics on how many of their patients are affected by urinary incontinence. Hey, it's greater than 50%. 50% of the women coming into your clinic have incontinence. You might want to treat them for it. And here are the tools to do that. You can provide as many things as possible to people, but if their schedules don't align with providing that extra care, it can be difficult. They are becoming aware of how prevalent of an issue this is. That's just the first step in our project. And we're hoping that, by giving all of these resources and providing resources that are, can be universally used, that we can kind of change the tempo and change the amount of primary care providers providing UI care to their patients.
Elizabeth Cope.
Thank you. And thank you again. I hope everyone please join me in thanking all of the panelists for their presentations today, as well as their responses to all of your questions. I know they were pretty active in the chat and in the Q&A responses, and then also in these discussions as well. And thank you again to AHRQ for their support for this initiative and the important work that's coming out. I am going to pass things off to my colleague, Sarah Hoyt, who's going to close us out and remind folks of the resources that are available.
Great. Thank you so much, Elizabeth. I want to echo Elizabeth's thanks to our panelists for your presentations and remarks today, and thanks to all of you who joined to ask questions. As previously noted, the resources discussed during this webinar, including an environmental scan and infographics, will be posted on the AHRQ website, and we dropped the link to that in the chat. As well as a link to where more information about the Managing Urinary Incontinence Initiative can be found. We also ask that you reach out via email if you have any questions. And finally, we ask that you please complete our survey to give us feedback on today's webinar. Should just take a minute or so, and we appreciate your time. But thank you all so much for joining us, and we hope you have a great afternoon.
Thank you. Resources and slides will be made available at https://www.ahrq.gov/evidencenow/projects/urinary/resources.html. For more information regarding the MUI initiative, please visit https://www.ahrq.gov/evidencenow/project/urinary/index.html or contact MUI_SE Center at academyhealth.org directly.